Hi, everyone. Happy Wednesday. I am Amy Hajari Case, the Chief Medical Officer at the Pulmonary Fibrosis Foundation, and I'm so glad to welcome you to the next installment of our disease disease state education webinar series. Today, I am joined by Dr. Pratik Gandiga. He is associate professor of rheumatology at my neighboring institution, Emory University in Atlanta. If you would just advance that slide for me. I have a couple of housekeeping notes before we get started. One is that this information that we'll be presenting today is really just for informational and educational purposes. And if you do have personal medical questions, they do need to go to your own personal physician. Next slide, please. Oh, sorry, that was one too far. But let me give our housekeeping notes just briefly. If you are new to our webinar series, have not joined us before on the Zoom platform, there are a couple of buttons that I want to call out on your screen. On your toolbar, you will have a Q&A box that you can click there. If you have questions throughout the session today, we will hold questions to the end and answer as many of your submitted questions as we are able to. So drop those there. If you are having difficulty with anything audio, video, anything on the platform, you can also drop a question there, and we will try to help you address that and troubleshoot during the session as well. So keep your eyeballs peeled for answers in that Q&A if you are having technical questions. We also have our show captions button that you can click there. If you are wanting to take advantage of closed captioning, we do have that, and you can go ahead and turn that on if you like. We will have a survey for you at the end of our session today, and so please stay with us for a few moments after the session, and we will get your feedback on the session and any future topics you'd like to hear about. Finally, before I disappear and turn over the microphone, I'm going to introduce Dr. Pratik Gandiga. He, again, is an associate professor and senior physician in rheumatology at Emory University here in Atlanta, Georgia. He heads the Emory Myositis Clinic and is an interdisciplinary faculty member of the Emory Interstitial Lung Disease Center. He has a number of hats at Emory and nationally. He is an active member of the National Institutes of Health International Myositis Assessment and Clinical Studies Group, and serves in leadership roles for the International Myositis Clinical Trials Consortium, or MCTC. His scholarly activities also include medical education projects through the American College of Rheumatology, the National Board of Medical Examiners, and the Society of Hospital Medicine. So I'm very glad to have you here with us today.
Thank all of you guys for being here, and from the very kind invitation from both Dr. Case and all of you guys for having me speak with you guys today. I think it's really important that a lot of the things that we talk about in rheumatology and in interstitial lung disease get really confusing. And so I really appreciate you guys learning more and hopefully sharing more with those in your community and those that are a part of your care team so that you can be an active participant in your care. I wanted to keep things really, really brief and basic today. And so I'm not going to go into a lot of detail, but kind of try and give you a 50,000-foot view, not to make you an expert, but that way you can have a little bit of a framework to be able to engage. And so we'll kind of go through some of those things really quickly, because the thing that I really want to spend the most time for is talking about whatever you want to talk about or asking questions about those things. So next slide, please. Very cool. So let's go ahead and start with some definitions. So like Dr. Case mentioned, I'm a rheumatologist. Rheumatologists do a lot of different things, but one of the things that we work with are these autoimmune diseases. Next slide, please. And so you may have heard of some of these things because they do intersect with this idea of interstitial lung disease. And so one of the traditional ways that interstitial lung diseases were grouped was grouping them according to the cause or the association. Next slide. So some of those terms are things that you may be familiar with, including idiopathic pulmonary fibrosis, like IPF. Next slide. And you may have heard of things like sarcoidosis. Next. But what we're really going to focus on the most today is what's traditionally called connective tissue disorder associated interstitial lung disease. And these are lung diseases that are associated with systemic autoimmune diseases. So let's get a little bit more into that. Next slide. So to be honest with you, I really hate this historic term of connective tissue disorder, because what exactly does that mean? And the problem with that is these things that are called connective tissue disorders were actually first described even before we realized that there was an immune system. So I'm going to use the term systemic autoimmune disease instead of CTD-ILD, but just know that this might be referred to both ways, especially since once a term is in favor, then sometimes it's really hard to change people's mind about it. So when you're talking with your doctors and your care team, you can kind of use both terms interchangeably. Next slide, please. All right, so what does autoimmune disease mean? Well, so autoimmune disease, we also sometimes say autoimmunity, is a condition in which the body's immune system mistakenly attacks its own healthy tissues and organs. Next slide. So all of us have an immune system, and the immune system is really, really complicated, and it all talks to each other, but it's divided into different parts. Next slide. So sometimes, to simplify things, I think of it sort of like when I'm thinking about branches of the military. You have the Army, the Navy, the Air Force, the Marines, the police force. They all do different jobs and they all kind of communicate with each other. But in the case of your immune system, they're all communicating and working together to try and help protect your body against foreign bacteria and foreign infections. Next slide. So normally, next slide. When you end up seeing a foreign invader, like a bacteria or a virus or something like that, what ends up happening is that sends a signal out to these different parts of the immune system. They all talk to each other, they all coordinate together, and then they figure out a way to attack that. And sometimes we call that term inflammation, even though inflammation is a little bit of a sloppy term, and there can be multiple different kinds of inflammation. In the case of autoimmune disease, this normal response is kind of a little bit askew. Next slide, please. So what happens in certain people is that you can develop autoimmunity or an autoimmune response. Next slide. And so what happens then is one or more parts of the immune system actually gets confused, thinks that normal healthy tissue is actually a foreign bacteria or a foreign invader, and ends up attacking that tissue. Next slide. And so when I think about autoimmunity, I kind of mentally end up associating in a couple of different ways. So the first big division for me, next slide, is whether this is one of these autoimmune diseases that affects just a single organ, or if it's a systemic autoimmune disease. And systemic autoimmune disease means that it has the possibility of affecting more than one organ system. Next slide. So single organ system things as just examples, because there's a lot of them, but things you may have heard about, like Hashimoto's thyroid disease or multiple sclerosis or MS or autoimmune hepatitis. So they affect just one organ system. And so the way that we approach them kind of really differs. And that actually is the case for some people with interstitial lung disease. And we can't find a systemic autoimmune disease, and they have that one isolated thing. Next slide. But some people can actually have problems where they have a larger, bigger picture autoimmune disease, and it has the possibility of affecting more than one organ system. And so sometimes we'll group them according to what parts of the immune system we think are the major bad players or kind of driving force, just to kind of keep ourselves a little bit structured and organized. In some ways, these divisions are a little bit artificial, and sometimes it's hard to put people into boxes, but at least this way we can kind of think about it. So you notice, next slide, there's some terms that we talk about, like sarcoidosis or sarcoid disease, and a lot of you guys are aware of those things. But other of these things can also involve the lungs. Next slide. And so you can definitely see that with a lot of different things, but the ones that you make most commonly run into are things in the lupus family, like lupus or systemic sclerosis, aka scleroderma, dermatomyositis, antisynthetase syndrome, Sjogren's disease. Some people may also have rheumatoid arthritis, which is one of our most common types of autoimmune disease, and sometimes rheumatoid arthritis can involve the lung. And then there's a lot of different types of vasculitis where the immune system accidentally attacks normal, healthy blood vessels. And so some of them can also involve the lung as well. Next slide. So one big question that a lot of people ask is, all right, so what causes autoimmunity and what causes these systemic autoimmune disease? Any thoughts or questions? So I see a couple of people in the chat having some ideas about this, but next slide. It's a little bit of a trick question because in most patients, you're unable to figure out a discrete cause where you can point to it and say, aha, this is where all of these things started. So the flip side of this is that honestly, in lots of people that have autoimmune disease, you shouldn't be sitting there and thinking about, oh man, what did I do wrong? Like, what could I have prevented? And most of the time, it's not your fault. And it's not something that if you had to do it again, that you could have prevented. Next slide. As rheumatologists, we've been trying to figure out some of these things because it's really interesting and maybe it gives us some insight into both the immune system and how to treat these diseases. We know that some people, because of their genetic backgrounds, their ethnicity, who their mom and their dad are, may have a predisposition to things. Toxins, including smoking or environmental exposures, or even prior treatments like certain herbal supplements or things like that, may end up triggering or contributing to autoimmunity. We do think that underlying immune dysfunction, including the inflammation that can be caused with diet and obesity, might do that. And in some people, it seems like infections can either trigger or worsen autoimmune processes. And so those are all things that probably contribute. But again, more than anything else, the take-home message is it's not something that we really have a lot of control over. Next slide. So big picture question, what does this mean for you? Next slide. Well, so why should you care if you have autoimmune interstitial lung disease, whether or not you have a systemic autoimmune disease along with it? Well, sometimes it helps us with diagnosing or subclassifying interstitial lung disease, because in some people, it's really hard to figure out, well, do they truly have this or do they truly have this? And if you know that they end up having rheumatoid arthritis or lupus, sometimes that influences that decision or that diagnosis. We always want to look out for other manifestations of that autoimmune disease we need to treat, and not just the lungs. And these are also giving us some clues in terms of other things that we should look out for. Like I said, these have the possibility of affecting more than one organ system. But the joke in rheumatology is that if you've seen 10 people with autoimmune disease, you've seen 10 people because everyone's a little bit different. And some of these patterns that we look for don't affect everybody. Sometimes it also helps with choice of medications or kind of knowing how things respond to treatment in some patients. And one caveat is that rarely some people can have more than one thing going on. So you may have something like hypersensitivity pneumonitis and may have an autoimmune disease, and the two may be related or they may be true and unrelated. Next slide. So what does systemic autoimmune disease look like? Well, this is a little bit of a trick question. Next slide. Mainly because the characteristics really depend on number one, the disease, and number two, it's really individual. And so sometimes we can make some generic type of statements and say that, all right, well, a lot of people with rheumatoid arthritis may end up having this, or people with antisynthetase syndrome may end up having these type of things. But really, every individual person is a little bit different. Unfortunately, like I said, there does seem like there's a genetic predisposition. And so in most of these autoimmune diseases, you'll see that it tends to affect women more commonly than men. And in adults, at least, most oftentimes, these are kind of diseases that start in early adulthood, like your 20s, 30s, 40s. Some of them can develop later on in life. But again, that's really an individual slash disease dependent type of a process. Next slide. And so those manifestations really also depend on the disease of the person. But what we're looking for with a lot of these type of autoimmune diseases is looking for the type of inflammation in the pattern of inflammation we would expect. And oftentimes those things can involve the, next slide, lungs in some people. And so we're always looking out for that. Next slide. Can involve certain joints that can cause a type of inflammatory arthritis. And this is different than the wear and tear osteoarthritis that some people can end up having. Next slide. Can involve the skin with some of these characteristic rashes that have characteristic patterns in your body, or when we look at them underneath the microscope. Next slide. It can sometimes involve muscles, especially kind of the muscles of the shoulder or muscles of the thigh, and that can sometimes cause weakness. Next slide. We're looking for other internal organ manifestations because sometimes some of our autoimmune diseases can affect the liver or the kidney or the heart. Next slide. And sometimes this can also involve the peripheral nervous system or the central nervous system. But again, not everybody gets everything. So even if you have two people with exactly the same subflavor of autoimmune disease, it's really depends on the person. Next slide, please. So the other big question we oftentimes get asked is how exactly do we diagnose autoimmune disease? And so I usually think of this in my mind sort of like a court case. And if you have a court case and you're trying to figure out, should I convict the person or not? Did they do it or not? Well, you're going to look at all the evidence that goes for that diagnosis, and you're going to go for all the evidence that goes against the diagnosis and see which way those things level out. Well, what kind of evidence can we gather? Next slide. Honestly, the biggest thing that we can end up doing is actually sitting down and talking to someone and examining them. And you'd be surprised that a lot of times the history, so what's happened in the past, what the characteristics of things are, what the involvement is at that point in time, really makes a big difference. And the exam, same thing. Oftentimes we'll draw some blood work, and oftentimes we'll draw these things called autoimmune serologies. So one big thing to know is that autoimmune serologies, honestly, they're the best that we have, but they're neither in and of themselves diagnostic. They're not in and of themselves dangerous. And so some people will say, oh, well, my rheumatoid factor was elevated. Does this mean I have rheumatoid arthritis? The short answer is it really depends, because that rheumatoid factor can be driven by other things. And in some people, it can be a consequence of normal, healthy aging. And we really have to put that into context. Sometimes I use the analogy that it's sort of like knowing what color jacket you're wearing and trying to figure out what football team that you end up supporting. And you can be like, no, man, I really hate the Georgia team, but red jackets look really good on me. So it's not a one-to-one correlation. Next slide. Sometimes those things aren't enough, and we may ask for other tests. So some tests, it really depends on the scenario and what we think is going to be the highest yield. But some common tests that you may see us asking for include imaging, like CT scans or images of the joints or the muscles, and sometimes looking at the pattern of inflammation on those things and kind of looking for evidence of destruction or damage is actually really helpful for us to both diagnose as well as get a sense of how active a disease can be. There are other tests we use to both diagnose as well as track disease activity. So it really depends on the scenario, but commonly you'll see us use pulmonary function tests. Sometimes we'll look at the electrical activity of muscles and nerves with things like EMGs, or sometimes we're looking for mimics, and so we'll ask for genetic tests that kind of rule those things out. Next slide. And in some cases, we actually think that the easiest way to get the diagnosis is to end up biopsying some of the affected tissue and looking at the microscope and kind of seeing what's the pattern of inflammation here. And so sometimes we'll may biopsy these characteristic rashes or lung or muscle or other things. And again, whether we need to do one of these things or not really depends on the situation, and really depends on you and your doctor and what the differential diagnosis, the possibilities and probabilities list are. Next slide, please. Right. So there are a lot of terms that you may hear us talk about when we talk about interstitial lung disease, especially when people have systemic autoimmune disease. And so you remember way back when, a couple of minutes ago, I told you historically, we've kind of grouped these interstitial lung diseases according to what we think that they're associated with or maybe caused by. And there are other ways of kind of thinking about grouping them together. And sometimes we'll think about the etiology, but we'll also think about what's the pattern of inflammation that we're seeing here, or what does it look like underneath the microscope, or what does it look like when we're looking at a CT scan. And so you may hear us talk about things like usual interstitial pneumonia, UIP, or non-specific interstitial pneumonia, NSIP. Sometimes we'll talk about organizing pneumonia, which is sometimes called OP or COP or BOOP or COP or BOOP. Sometimes we'll hear us talk about diffuse alveolar damage, DAD, or diffuse alveolar hemorrhage, DAH. So it's a really big alphabet soup. And if you're confused, just don't feel bad. A lot of doctors get confused by these terms as well, because we're always constantly tweaking and refining these things. But what you kind of need to know for thinking about these things is these are all ways of describing how much inflammation is there, what's the type and the pattern of inflammation, and how much scarring, how much fibrosis do we end up seeing? There are other complications. And sometimes it's helpful for us to kind of think about for both diagnostic purposes, and sometimes that gives us a clue in terms of what things we think might be helpful for that person to get them doing better. Next slide, please. So a really common question that I get a lot is, why am I short of breath? I have interstitial lung disease. Well, when we think about all the things that are contributing to that, well, there is some component from that active autoimmune lung inflammation, but there's also going to be a component from that physical deconditioning that can sometimes happen. Unfortunately, sometimes when you end up having these autoimmune inflammation, it causes fibrosis or scar tissue to develop. Sometimes some of the medications can cause side effects that can sometimes contribute to the shortness of breath. And there can be other stuff that contributes, like for instance, if people have diaphragm muscle weakness or things like that. Next slide. But part of the point is, next slide, when I'm looking for a person, it's really important for me to figure out what percentage of the pie is these different things. Next slide. So trying to figure out if it's active lung inflammation versus is this kind of some of the damage that's there? Is this due to the physical deconditioning? Is this due to the medication side effects? Is really important, because it's really not fair to you to just assume, oh, if you're short of breath, it must mean that we need to put more immune suppression or more treatment on board to try and quiet down inflammation, because it might be one of these other things as well. And so kind of thinking about that and realizing that is really important for both doctors as well as patients. Next slide. Right. So how are these systemic autoimmune diseases treated? Well, the treatment really kind of depends on the person. Next slide. Medications you commonly see us use oftentimes are what's called glucocorticoids or steroids. So common things like this might be prednisone, medrol, prednisolone, solumedrol. And so the reason that we like and hate steroids is that of the medicines that we use, they're one of the ones that have the the biggest risk of long-term side effects. But on the flip side, they tend to affect the immune system in a lot of different ways. They tend to be a little bit quicker at quieting down some of that active autoimmune attack. And so oftentimes they may be either temporizing medicines while we're trying to wait for something else to get on board, or they may be things that we're using in the short term to try and help if someone's having a flare. Next slide. You may hear us use conventional DMARDs. And so the reason that they're called conventional disease-modifying anti-rheumatic drugs, or DMARDs, is because they've been around the longest. And because they've been around the longest, we tend to know them a little bit better, and they tend to be cheaper and generic and things of that nature. So common medicines you may hear us use for that are things like methotrexate, azathioprine, also called Imuran, mycophenolate, also called Cellcept or Myfortic. And just because they're older doesn't mean that they necessarily are worse or that they don't work as well. It's just that they happen to be around a little bit older. Next slide. Sometimes we'll use intravenous immunoglobulin, where when you take blood from people that have donated blood and you purify out some of the proteins and the antibodies in there, you can mix together about 10,000 people's donated pooled blood, purify it and give it back. And in some ways that can try and help quiet down active autoimmune inflammation. Next slide. You may hear us use things for B cell depletion. So B cells are part of the immune system, and sometimes in some patients, we think that that's one of the parts that needs to be quieted down. And so common medications include things like Rituxan or rituximab, but you may hear us use other medications as well, especially as there are newer B cell depletion related treatments on the market. Next slide. And then there are other medications that we sometimes end up using. In my personal practice and the patients I see, oftentimes we're using these calcineurin inhibitors like cyclosporin or tacrolimus, also called Prograf. There are other medicines like Xeljanz or upadacitinib, which is a Rinvoq. Those are a class of medicines called JAK inhibitors that you may see advertised on TV. In some patients, we may think about things like cyclophosphamide or other more potent chemotherapy agents. We may think about things like clinical trials and experimental medications or other procedures. And really that context really makes a big difference. Next slide. But just as important as the medications are some of these non-medication interventions. So we really want to kind of make sure that we're doing things to address the person as a whole. And that includes things like exercise, physical therapy if they might need it. We're trying to avoid additional injury. And so big risk factors for that is if you're smoking or around secondhand smoke, trying to minimize or get rid of that completely. Sometimes we have to think about ionizing radiation. So people that might be getting treatments for cancer or things like that, and kind of trying to figure out what's the risk benefit of giving radiation therapy for that. Nutrition does play a role, and so it's really hard to study nutrition. So if you're going to ask me, oh, what's the superfood that I should eat? I'm going to tell you it's really impossible for me to say because I don't think that there is one. But honestly, basic principles like trying to minimize the amount of refined sugars and processed foods in your diet, eating more fruits and vegetables, making sure that you're kind of limiting the intake of fats, but when you're eating fats, eating healthy fats, all of those things are really, really useful and helpful as adjuvants, and they kind of work together with the medication, the non-medication interventions as a whole. Next slide. So the other thing to take home is that it's not unusual to need combinations of medications, and kind of that really depends on the person. And so every time I see somebody, I'm trying to figure out, all right, where is their disease? Where is it active and how active is it? How are they responding and tolerating treatment? Unfortunately, the state of the science is still that in many people, we won't know how well a medication is tolerated or how well it works until we end up trying it. So we may need to try multiple options until we can kind of figure out what the scenario is for that particular person. The other take-home message is that combination might actually change over time. So you can imagine the analogy of a building on fire. Well, as the fire gets smaller, sometimes we can send some of the fire trucks home. Or if the fire was small and now it's blazing up again, we may need to call in some more fire trucks in the future. Next slide. All right, so question for all of you guys. What's the best medicine? So you can go ahead and put in the chat and let me know what you think the absolute best medicine for treating your autoimmune disease is. A couple of responses and things like that. And a couple of people got the thing. Next slide. So really a trick question. So like we said, everyone's an individual and the scenario changes over time. So maybe the better question is, what's the best medicine for me at this particular time? And things that kind of influence that decision include the degree and the locations of your autoimmune disease activity, what medications you've tried in the past, what type of autoimmune disease that you might end up having, logistics of the medicine. So some of these medicines are pills, some of them are injections, some of them are infusions, and that plays into things. We really want to take into account other medicines you might be taking or have taken in the past or may need in the future, as well as your other medical problems, your comorbidities, and of course, your preferences. And so you can see that this really needs to be a conversation between any particular patient and their care team, their physicians. And oftentimes people that have autoimmune disease may actually end up having more than one care team member. So they may have their lung doctor, their pulmonologist, they may end up having a rheumatologist or a neurologist, a neurologist treating the nerves, or a nephrologist, someone who deals with the kidneys. And sometimes, in some cases that are really complicated, people may have more than one pulmonologist, and so they may have their everyday kind of general pulmonologist who's they're seeing on a pretty regular basis, but may end up having a subspecialist that they're seeing a little bit less frequently to try and help give a little bit of extra insight. And so really kind of knowing the role that everyone's playing and making sure that everybody's working together is really, really important for your care. Next slide, please. Other question for you guys is, can you exercise with autoimmune disease? So I'm going to give you a pause, let you put some of those questions and comments into the chat. Next slide. So the answer is absolutely, please do. It actually helps with the physical deconditioning and it can help with medication side effects in some cases. But it's really interesting that in a lot of studies, we've realized that that routine physical activity actually helps regulate the immune system. And so it may end up actually helping control the disease and kind of making those medications work a little bit better. So a couple of really, really big caveats with this. Number one is talk with your doctor and your care team and kind of make sure that you know if it's safe for you to exercise and what limitations are needed in your particular case. And we really want to tailor that exercise restriction as well as the exercises themselves to your particular needs at any given time. Oftentimes we're looking for combinations of things that are helping with strength, but also things that are helping with endurance. Stretching is also really important. In some cases, it's actually helpful to have a physical therapist and an occupational therapist, or even sometimes a rehabilitation doctor to try and help give input and try and really customize that regimen for you. And really, it's important to know your limits and kind of talk with your physician in terms of what those limits should be. And so oftentimes in many patients, the idea is that it's a little bit better to do moderate activity a little bit more frequently than doing really heavy activity all at once, and kind of really working on building things up as someone who's like a marathon runner and needs to end up training every day, not just going out and running a marathon every day. I will say that you should be cautious around testing time and talk with your physicians about that, not necessarily because it's dangerous, but because sometimes if you're exercising, you can throw off some of those numbers and make it a little bit harder to interpret some tests. And that depends on the test and depends on the person, but that is something to keep in mind. Next slide. So last thing that I'll end with is a couple of minutes about things I'm excited about. And so these are all completely my biases. And so I'll put that out there. Next slide. But I think it's a really hopeful time for things. And it's really nerdy, but one of the things I'm really excited about is the idea that we're trying to figure out like what to call these autoimmune diseases and how to actually group them together and make them easier to study. Next slide. So you can see that, I gave you a hint of how we ended up traditionally thinking about these autoimmune interstitial lung diseases, but over time you can see that things don't stay static in science, and so they keep changing, and we can keep trying to refine and figure out what's the best way of thinking about things. Next slide. And you can see that not just us actively thinking about it, but trying to leverage things like artificial intelligence, or actually kind of look at things in terms of what they look like on the CT scans, and using those things to help try and group and kind of come up with ways that we can end up hopefully trying to help put people into some of these cubby holes a little bit more readily, and see if that ends up helping influence how we're going to treat them or how we're going to help out and learn more about the disease in the future. Next slide. One thing I'll make a plug for is that antisynthetase syndrome, which is a subtype of dermatomyositis, depending on who you talk to, is really interesting and near dear to me because I'm a myositis aficionado. And about 30% of all patients with antisynthetase syndrome actually have interstitial lung disease. We're actually did a very large international study with a couple of hundred people from around the world, and actually came up with the first first diagnostic and characteristic criteria for antisynthetase syndrome. So I'm hopeful that this will also give us some insights that'll help us out in terms of studying this disease and hopefully translate into the clinic. Next slide. So things I'm also excited about are these clinical trials, and also these clinical trials specifically for autoimmune disease and autoimmune interstitial lung disease. So if you want to know a little bit more about these, you can go to clinicaltrials.gov. That's a government-based website. And so in the US, at least, people that are running a clinical trial are required to register with clinicaltrials.gov. And you can end up searching there. So in this particular case, I was searching just for autoimmune diseases and interstitial lung disease. Next slide. And you can see that right now there's almost 200 studies that are actually active in the US and some other places that are actually looking at autoimmune interstitial lung disease. And so if you're interested in learning more about those things, then you can end up filtering this a little bit more and looking for things that are intervention versus kind of trying to do natural disease history and things of that nature. If you're interested in those things, contacting the study coordinators or talking with the physicians is really helpful and useful and important. Next slide. And again, I'll also make a little bit of a plug for, I'm excited by this Myositis Clinical Trials Consortium. So this has been something that we've been working on for a couple of years, but it's really the last year that this has really taken off the ground. This is a collaboration from around the world. So far, we have about 750 members. There include doctors and people that are interested in running clinical trials, but it also includes patient support organizations as well as pharma partners, and trying to get that 300 360-degree approach to how can we make clinical trials better? How can we try and expand, trying to get these medications to the market to help people out a little bit more quickly? But how can we also make sure that we're making sure that these medicines are safe and effective? Next slide. And the last thing I'll mention, because a lot of people have probably heard about CAR T therapy, CAR T cell therapy. And so what happens in CAR T therapy is, you remember how I said that the immune system has multiple different parts to it? Well, what we can do is we can take one of these parts from a person, try and modify and train it to target particular cells, and then give that back to a person to try and attack those cells. And so it's been used in the past for treatments for cancer, and it's been had some effect of it. Over the last, especially the last 2 years or so, there have been case studies and reports and trials now where we're actually trying to say, can we use this to help people that have autoimmune disease? And I will emphasize that this is really early stages, and this is still considered experimental technology. But at the same time, this is really exciting and it's hopeful, because a lot of these people that were refractory to some of the other ways of treating their medications ended up doing better. I'll also make a short little plug in terms of a lot of this research, and a lot of the stuff I showed you is actually through things like the National Institutes of Health, the NIH, and the Health and Human Services. And so it turns out that a lot of our research and a lot of our discovery, including probably the medications that many of you guys are taking, actually come from your tax dollars and trying to help support these things. And so, especially with some of the changes that we've seen, I think it's really important for us as people that are interested in autoimmune disease or health in general to end up making sure that we let our Congress people know that this is something that's really important, and that we need to continue to end up supporting this in the future. Next slide. So in summary, next slide. Things to take home are that interstitial lung disease can sometimes be part of a larger systemic autoimmune disease, but this depends on the person. Next slide. That the manifestations, the severity, the response to treatment is really different for different types of autoimmune disease, but especially for different people. Next slide. That treating your autoimmune disease should be a partnership between you and the rest of your care team members. Next slide. And that there are a lot of things that we don't know, but it's really an exciting time for all of us, because there are a lot of people working to try and make things better. Next slide. So I'll end there and kind of open up the floor for discussions.
That was really wonderful. Thank you so much. It's a big topic, but I think you made it very accessible, at least for me. um, so I'm excited to get to some questions, and I'm also excited that I have a captive rheumatologist to ask my questions of as well. So I might slip some of my questions in too. um, but we'll start with some that were submitted and not my questions per se. Before we do, I do want to let everyone know that in the chat function on your toolbar, we have Dr. Gandiga's slides there that you can download. And I know you pointed to clinicaltrials.gov. I also want to put a plug in for the Pulmonary Fibrosis Foundation's Clinical Trial Finder. And we should have a link to that that's dropping in the chat as well. And that is just a different way of being able to search for these studies and filter them a little bit more easily, but it is the same information as clinicaltrials.gov. So please check that out if you're interested in any of these topics. Okay, so an interesting question that was submitted was about prevention, which I think is a very interesting topic, and I think there is a lot of interest from a research perspective in this, but I think it's still also quite early. As somebody who has potentially multiple risk factors, perhaps familial pulmonary fibrosis in their family but not themselves, and also an underlying autoimmune disease. Are there actions that a person can take to try to prevent their risk of developing interstitial lung disease?
That's a really great and it's a really interesting question because you're absolutely right. That's one of the things that I'm excited about trying to figure out more about the immune system and autoimmune diseases in general. So one take-home message is that genetics do play a part in things, but we know that a lot of it's environmental factors. So there were these studies with identical twins. Identical twins means you have exactly the same genes. And so if you have an identical twin with lupus and you guys grew up together, then you have a 1 in 4 chance of developing lupus, which is to say that with exactly the same genes and exactly the same kind of environment, that 3 out of 4 times one person won't develop lupus and one person will. And so from that standpoint, it's not a one-to-one correlation, but in my mind, it's kind of trying to tweak your percentages and kind of trying to stack the odds in your favor. Believe it or not, the best study and the best data that we end up having are for things that you don't think are all that quote unquote sexy, but it's things like routine physical activity and exercise, making sure that you're trying to eat healthy. And eat healthy doesn't mean that, oh, I'm eating this superfood, but it rather means that you're trying to limit the amount of refined sugars, refined sweets, limit the amount of processed foods that you're seeing. Some studies suggest that maybe trying to limit the amount of animal protein that you're eating is helpful. But if you are eating animal protein, making sure that it's baked or grilled instead of fried. And then also increasing the intake of fruits and vegetables. And that's one that all of us that are Americans, myself included, really need to work on because all of those kind of fruits and vegetables really kind of help out. When I talk to somebody about these things, I try and make it simple. And I say, rather than worrying about how many micrograms of selenium that you end up getting that week, you can think about it as eating a rainbow. So every single day, you should be eating some things that are green and leafy, but over the course of the week, you should be eating some fruits and vegetables that are red, yellow, blue, purple, orange. Those different colors really kind of help make sure that you're getting different nutritional profiles into your diet, and the variety is really useful.
Great answer. Thank you so much. We have several medication questions. I'm going to ask about prednisone. You mentioned corticosteroids. And from my experience, there are some patients, knowing that you mentioned that there is some trial and error associated with treatment of autoimmune related interstitial lung disease, and also that sometimes you need combination therapy. Are there patients, in your experience, as well as maybe is there a literature basis for long-term prednisone use versus another immunomodulatory agent versus a combination versus, in a low dose or a high dose? Can you talk a little bit about that? I know that wasn't quite a great question, but maybe you can
No,
pontificate a
absolutely.
bit.
Incredibly excellent questions. Actually, one that I've gone to hour-long discussions about in the past because I think it's a really kind of interesting area, and it's actually a really hard question to end up answering. So, by way of kind of the way that I think about things, at least, is always kind of saying, all right, any medication, prednisone included, has a pro to taking it and has a con to taking it. And any medicine has a pro and a con to not taking it. And so part of it is kind of trying to individualize and saying, all right, well, I can't predict the future, but what are the pros and the cons of taking it versus what are the pros and the cons of not taking it? And that really depends on people. Prednisone has and steroids have three big properties that we think of as rheumatologists. One is that they do affect the immune system and they are immune suppression, and they affect the immune system in a lot of different ways because they're kind of a little bit of a broad sword through those things. They also have effects in terms of pain relief, sort of like these opioids end up having, and they also have anti-inflammatory effects. Sometimes you can think of it sort of like things like Advil, Aleve, naproxen, and so all of those properties kind of really sometimes come into play. And so one of the things that we've struggled with is kind of thinking about some of these autoimmune diseases and kind of saying, all right, is the prednisone going to be helpful to kind of get rid of completely because of the long-term side effects, including risk of low bone density, increased atherosclerosis and cardiac risk factors, diabetes risk, infection risk, etc., versus what are the benefits out of it? For a lot of people that have interstitial lung disease, where they may have some fibrosis and scarring, honestly, part of the reason that we keep them on long-term steroids isn't necessarily the autoimmune disease activity, but rather the anti-inflammatory properties. And, I know Dr. Case, as a pulmonologist, probably has a lot of patients that may have more mucus or reactive airway disease because of damage to the lung in the past. One of the other issues that kind of comes into play with this is that we know from a lot of the studies, including some of my colleagues that work locally at Birmingham, Alabama, that the risk of prednisone and these steroids is really exponentially dose dependent, which is to say there's a really big difference between being on 20 milligrams of prednisone versus 10 milligrams of prednisone, and a difference between being on 5 milligrams of prednisone versus 10. And so one of the things that we usually try and take into place is kind of saying, all right, if someone ends up having this thing where I can't get down the prednisone because their autoimmune disease keeps flaring up, is the risk of putting on another medication or changing the tack that we're doing to try and get rid of that prednisone, or kind of at least lowering down the dose, worth it? And it depends a little bit on that person and a little bit on the treatment philosophy. In many patients I have, the answer for that is yes. And in some patients, the answer is no, and we do keep them on low dose prednisone in the long term.
That's excellent. I think that's such an important topic, and I'm actually glad to hear that there are long discussions about it, and that it's not just me wondering in my own practice. I think our very engaged audience must have been scoping you out on LinkedIn or something, because I have a lot of questions about anti-synthetase syndrome, and a lot of interest in this topic, which I know you're glad to hear that there is interest in that people are being correctly diagnosed, potentially, because it is a difficult, in some cases, diagnosis to make. Could you, since we got a big broad overview, but there's a lot of interest in this topic, could you talk just for a minute about what is anti-synthetase syndrome, how it affects the lungs, and then other organ involvement?
Oh, I'm more than happy to. This is one of my favorite topics, in fact. So when we think about the world of autoimmune myositis, so the word myositis means that it oftentimes in some people cause muscle inflammation. And so back in the day, when it was first described in the 1950s, you had two flavors. You either had polymyositis, which is this characteristic muscle inflammation, or you had that plus rashes, and that was dermatomyositis. And those rashes are kind of characteristic. Since that point in time, especially in the last 4 to 5 years, we've really started trying to subdivide that a little bit more, because we realize that things are very different. And so within that dermatomyositis family, you'll end up seeing a lot of people end up being separated out. And one of those groups is called anti-synthetase syndrome. And some people think it should belong in a category by itself. Some people think it's a subflavor of dermatomyositis. But anti-synthetase patients tend to have a couple of features that tend to be common. One is that in many of them, they can get autoimmune inflammation at the skin with these characteristic rashes. In many of them, they can get autoimmune inflammation of the muscles at the shoulders and the thighs, but that really depends on the person and the type of autoimmune disease they have. And then in many of those cases, they end up having autoimmune interstitial lung disease, where they have inflammation of the lungs. And typically that's in that NSIP pattern. And that's why I said that sometimes some of those radiographic patterns, what we see on CT scan, are helpful for diagnosis and kind of the characteristics of things like that. So since coming up with this idea of anti-synthetase syndrome, we've actually even realized that within that category, there are different subcategories, and they act a little bit differently. And so I saw some questions in there in terms of these autoantibodies and these how we use them. So autoantibodies are sometimes helpful for kind of giving us another clue or a piece of evidence that can support a diagnosis of autoimmune disease, but sometimes they're also helpful for trying to subdivide patients. And so knowing if someone has anti-synthetase syndrome, if they have a positive anti-synthetase antibody, helps me think about what's the percentage chance that they're going to develop interstitial lung disease or one of these other manifestations. So oftentimes I tell people, know your antibodies. And so common antibodies you may see are things like Jo1. That's probably the most common one for anti-synthetase. But there are also things like EJ, OJ, PL7, PL12, and also some of these novel ones like anti-YRS or anti-Ha antibodies. And so all of those things kind of give us a little bit of clue, and we're hopeful that that'll also help us in the future, kind of trying to subdivide and say, these patients tend to respond better to this, or these patients tend to respond better to this. We've known over the last couple of years that we do still use conventional DMARDs for a lot of these patients, but it does seem like a lot of these patients, especially that are anti-synthetase antibody positive, may have a good response to B cell depletion. And so if those conventional DMARDs aren't working, that's oftentimes a clue for me to try and reach for those things a little bit earlier than later. But again, that's a really individual type of a situation. I think anti-synthetase is really important because we're also using it both in myositis and in autoimmune disease as well as kind of a model type of a disease where we can say, all right, let's come together and figure out what does it mean when someone's getting worse? What does it mean when someone's in remission? And how can we make those definitions? Because again, those definitions are important to us both as clinicians, but also as researchers to try and figure out how can we effectively treat people.
So I'm going to ask this question because you said remission. Do systemic autoimmune diseases that have lung manifestations have remissions? And if so, what does that look like?
That's a great question. And so the word remission is a little bit of a tricky word because everyone kind of has a little bit of a flavor of what they think that it means, but at the same time, the devil's in the details. And so what most people that are talking about remission means is that I don't have any active autoimmune disease manifestations or inflammation right now. That doesn't mean that you might not have symptoms that are due to the damage that the disease has caused. So for instance, if you have lung fibrosis or scarring, you may still have shortness of breath or some problems with that. But with remission, what we're looking for is how can we tell whether that person has active autoimmune disease or not, or is there a degree of autoimmune disease that we say that it's all right to have this much active inflammation, but no more than that. Part of the other question with remission is, well, there are two kind of flavors of remission. Is there a remission meaning that this person is off of all of their medications completely and is able to continue to move forward without any active autoimmune disease, versus patients that are in remission, but they have to continue on medications indefinitely? So the conventional thinking is that most patients with autoimmune disease are going to need something for the long term. And again, that something really kind of depends on the person, depends on their disease and the disease manifestations. There are, I can think of off the top of my head, in my practice at least, that there are a handful of people I've had that have, for whatever reason, their autoimmune disease has quieted down and they're on minimal medicines or off medicines, and they haven't had any disease activity or flares or progression for multiple years. But I think that that's really the minority of people. Most people are going to need something, but the other kind of take-home message is what that something is really depends on your degree of disease activity at that moment in time and what you've seen in the past. And sometimes we've been able to transition people where we can go from a more potent medication to a less potent medication, and still keep their disease under good control in the long term. And we're always trying to balance the risks of the medicines, the side effects, the infection risk versus the benefit that somebody's going to end up getting. I think one of the big projects that's really interesting for the Myositis Clinical Trials Consortium is actually there's an international kind of meeting with a lot of pulmonologists, rheumatologists, and neurologists to try and end up saying, all right, well, with interstitial lung disease, for myositis at least, what does it mean when someone's having progression? What does it mean when someone has activity? And what does it mean when someone's in remission? And can we come up with kind of consistent definitions for that so that everyone's talking about the same thing?
I think these are such important questions to answer as we're trying to, really put all of this knowledge into practical practice and take care of patients. And particularly since there's so much variability from person to person and disease to disease, that individualizing for that person, and if we can understand how to do that better, is going to make such a difference in the future. It is wonderful to hear how far we've come in this field, and it is humbling to know how much there is still to do. But I think you've answered so many questions, and we are out of time for more. I think we could go on, which is why I brought up it being a bit humbling. But thank you so much. I am going to, let's see, we've been through that. Just thank our sponsors for our webinar series today. Remind everyone that this is your last opportunity to download the slides in PDF form from the chat function if you would like to do so. Check out the clinical trial finder if you're interested in looking into what clinical trials and research studies are available for autoimmune and connective tissue disease. I'm using the old term, related interstitial lung disease. And I will once more thank you, Dr. Pratik Gandiga, for joining us today. This has been a wonderful, very informative session. And everyone, looking forward to seeing you again next month for our future webinars. Thank you.
Thank all of you guys for being here and for doing what you guys do.
Have a great day, everyone.